Hello, good day. This is the Acupuncture Sports Medicine Webinar series. My name is Whitfield Reaves, and I will be with you on 18 one-hour webinars on a variety of what we consider to be very important clinical topics, the kinds of injuries, musculoskeletal disorders, and pain syndromes that we all see in clinical practice, regardless of whether your specialty is sports medicine or if you are an internal medicine practitioner. These are all the kinds of things that the North American patient has experiences in daily living, whether they are active, athletic, competitively athletic, elite athletic, or possibly even the inactive, can experience many of these conditions, such as the osteoarthritic hip and knee. That does not necessarily have to be an orthopedic or sports medicine complaint of an active or athletic person. So we feel like we've selected very, very practical, very common clinical complaints, and we feel like we have also selected conditions that lend themselves to instruction in this format. Sometimes some of these conditions are so wildly varied with so many causes, so many different possible pain generators, or so many different syndromes that may be present that it doesn't lend itself to saying, hey, here's how you fix this problem. So we've tried the best we could to choose common and also clinically easy to grasp conditions. Let's look at a few of those. The shoulder and upper extremity will have stiff neck due to the levator. Some of you may have already seen this as we've had this up for quite some time. Shoulder pain then gets differentiated into the supraspinatus, the infraspinatus, the bicipital muscle, the acromioclavicular joint. And rather than living with what the traditional texts tell us, which is shoulder pain, periarthritis of the shoulder, which I have no idea what that means, LI15 and a bunch of local points. It isn't sufficient to get swift clinical results, and nor is it efficient to be able to communicate to your patient what is wrong. And finally, it's not efficient to discuss with their referring physician or other physiotherapists or orthopedists in their whole treatment regimen of what you're doing and why you're doing it. So we very much are using anatomical language, trying to differentiate according to the anatomical tissue that is affected. Therefore, we are going to talk about manual muscle testing, other orthopedic tests. Sometimes it's too difficult for us to show you those tests, and we're constantly saying, okay, go onto YouTube. There are various sites that will show you very good footage of doing this test. So we don't cover all the orthopedic tests when it's not practical for us to do that, or we can't do it well within the context of a webinar. But we are trying to differentiate and trying to talk about what is the anatomically injured tissues and how do we get access to those tissues. Thus, you'll hear the language anatomically significant points like small intestine 12. If we go back here to the supraspinatus, small intestine 12 is at a primary trigger point of the supraspinatus muscle. The supraspinatus muscle is the most likely muscle to be injured in acute or repetitive stress shoulder trauma. So here we have an anatomical significant point that's in the belly of the muscle. It is the motor point where the motor neuron enters the muscle to innervate it and bring chi to the muscle. And it's a trigger point, a zone with predictable chi and blood stagnation. So we'll be using illustrations such as this. We will be talking about anatomical significant or the anatomical individuality of some of these access points. Many of them are acupuncture points, many of them are not. And so we're going to have to make up some points. We're going to have to get some large intestine 15.5 and some extraordinary points that you perhaps may not have heard of. So we will have a lot of differentiation of the shoulder. We'll talk about carpal tunnel and epicondylitis, and perhaps as time goes on, we may add some other webinars for the upper extremity and the neck. For the lower extremity, we start in the pelvis with a lot of discussion about the gluteus medius and the gluteus minimus, two extremely important muscles for pelvic stability, core stability, where there is not an acupuncture point located. Bladder 53 and 54 are not on this. Gallbladder 30 is too far inferior. Gallbladder 29 is too far anterior. So we have these very important points, very important tissues involved in many problems such as hip bursitis, hip joint arthritis, iliotibial band syndrome, even contributing to knee pain. Many new studies are showing that the gluteus medius is involved in patellofemoral joint syndrome in terms of pelvic stability. So we have a lot of interesting material, probably not new to most of you. You palpate the pelvis, you find these Osher points. We're only going to try to show you why they're Osher, what is their anatomical significance, and how you can predictably get to those points and not just rely on Osher points and not get distracted by Osher points that are secondary to some of these primary points. And from the hip, we'll move down to the knee and the hamstring and shin splints. For instance, in Achilles tendonitis, we'll show techniques of threading the tendon. With plantar fasciitis, we'll show techniques of threading onto the periosteum of a significant injury here that where almost a needle laid across the periosteum at the attachment of the plantar fascia is important. With low back pain, we will focus on the quadratus lumborum, a hugely important muscle. No major acupuncture points, no well-known extraordinary points for that muscle. So we got a lot of interesting conditions. I love talking about all of these. Some of them are frustrating for me. I don't bat 1,000 on all of these conditions, and when I don't, I tell you, so that we can together examine the difficulties of treating some of these conditions and some of the difficulties in determining what tissue is really involved and therefore where we put the needles. But once we take an anatomical approach, we will always then translate into Jing-Lo, into the meridians and the distal points. So we will not leave out TCM. We will talk about a lot of distal points that are useful. We will talk about a lot of empirical points or some empirical points using opposite side, opposite extremity. And we will talk a lot of times about trigger points. Here we have this Janet Travell showing the radiation pattern of trigger points. So we'll bring in trigger points into the mix. We'll bring in some motor points that come up from Chan Gunn and Matt Callison's work. We will show techniques such as this, where we needle subacromially from large intestine 16 to large intestine 15. we try to thread a needle under the AC joint for various purposes. So not only are we going to needle into belly of muscles and needle into motor points and trigger points, we're going to talk about needling into spaces such as the subacromial space. We're going to talk about needling joints, laying needles along the opening of joint spaces, such as the all-important acromioclavicular joint here. So we will talk about tricky diagnoses such as the levator that often gets lost in the whole TCM approach. A contracted levator, for instance, levate means elevate, elevates the scapula, will produce all of these trigger points up here in the upper trapezius, gallbladder 21. Many practitioners are needling gallbladder 21 endlessly, only to find that relaxing the levator, getting scapular depression, will deal with the problem very, very well. So we will discuss the common patient complaints of each of these conditions with the idea that you will come out of these webinars knowing what the patient will most likely report to you, and therefore how you can be arriving at a diagnosis very quickly just from the interview process. We'll talk about common treatment protocols where we're talking about the belly of the muscle tendon junction, the tendinous attachment, the subacromial space. We'll be describing those anatomically significant local points. And we will then, as I said earlier, combine them with the very important distal points. Like, for instance, if we have a subacromial problem, Li16 to Li15, obviously, this is Yang Ming. We've got some wonderful points, from bleeding the Jingwell point to activate the tendinomuscle meridian at Li1. We've got a Shu stream point at Li3. We've got a Yuan source point at Li4. We have a Hussey point at Li11, all of which are to be considered as distal points that could have helped this problem. So we will absolutely not leave our roots as traditional Chinese medical practitioners, but more we will integrate and add to those roots with modern anatomical and orthopedic language that will help bring so much more clarity to where we're putting those local needles. And we're not going to get tricked, for instance, by a trigger point that refers pain, say, out to the deltoid, but the stagnation is back at small intestine 12, the supraspinatus. We're going to make sure that whenever possible, we are needling the primary stagnation and not into zones of referred pain where the needle is most likely going to have very little effect. So this is the sort of an introduction, give you a feel for the program